Lower GI bleeding. Cases and discussion. Part 1. Infants. Noah is a 2-month-old boy who came to the office with complaint of several diapers with blood in them for 2 days. He was doing well on regular formula, except that he grunted a lot and stools were slightly loose. His exam was normal. He was changed to an extensively hydrolyzed formula and did well. His diagnosis: milk protein-induced proctocolitis. Anna is a 3-month-old girl who came to the office with complaint of blood in the stools for 1 day. She had a history of hard stools, had tried Karo syrup and a formula change. Her exam showed a mild tear in the posterior anal mucosa. Her formula was changed, lactulose syrup prescribed, and instructed to apply some Vaseline to anal area. She did well afterwards. Her diagnosis: anal fissure due to constipation. Emma is a 7-month-old girl who came to the office with a complaint of watery stools with blood and mucus for 2 days. She was fussy, had loss of appetite, but no vomiting or fever. Her mother also had diarrhea and abdominal pain. Her exam showed good hydration with mildly distended abdomen and increased bowel sounds. Her diagnosis: Salmonella infection. John is a 7-month-old boy who came to the office to show us a diaper containing a red currant jelly looking stool. He had a 2-day history of sudden episodes of crying and vomiting, but seemed normal in between except sleeping a lot. His exam was normal except for mild distended soft abdomen. He was sent to the ER where sonogram showed a telescoped bowel. He required surgery and then did well. Diagnosis: Intussusception. There are several possible causes of blood in the stool in infants. Causes are anal fissure, milk protein-induced proctocolitis, bacterial gastroenteritis, intussusception, duplications, vascular malformation. Other causes seen more in newborns are necrotizing enterocolitis, malrotation with volvulus. Anal fissure. This is the commonest cause of rectal bleeding in infants. It's due to a mucosal tear in the anal lining caused by passage of large or hard stools. In the history, there is often constipation. Exam shows a slit-like tear, usually in the midline anterior or posterior in the anus. The treatment is to apply Vaseline to the area several times a day and soften the stools with dark Karo syrup, apple or prune juice in older infants, or prescription of lactulose. They will often heal after several days but may leave an anal skin tag. Milk protein proctocolitis. This is a common cause of blood in the diaper in early infancy. The protein in certain foods causes inflammation of the distal colon and rectum, proctocolitis, and this causes bleeding in stools. The most common cause is cow's milk protein from either formula or through breast milk. Other foods are soy, eggs, or corn. It may present as well looking with blood in the stool, or baby may be fussy with loose stools and blood. In the history, important things are the infant's formula type, feeding, and any changes. If breastfeeding, then the mother's diet, which should include her milk, dairy, soy, and corn intake. In the physical exam, Check on nutritional status with the height, weight, and general exam including abdomen and anus. Labs often are not needed, but you could consider hemoccult testing of stool to confirm the presence of blood. Sometimes if there is a poor response to therapy, then endoscopy may be needed, which may show red areas in the distal colon and biopsy findings of increased eosinophils. Management. In formula-fed infants, change to an extensively hydrolyzed formula, such as Nutramigen or Alimentum. A few infants may not respond and so need an amino acid-based formula, such as Elicare or Puramino. In breastfed infants, mother has to eliminate all cow's milk and dairy from her diet. If bleeding persists, then she will have to also eliminate soy, eggs, and corn from her diet. For most infants by 12 months and some by 9, the protein can be gradually reintroduced without having any more symptoms or problems. Bacterial diarrhea. Acute diarrhea in children is more likely caused by viruses, but sometimes may be bacterial, which may cause some blood in the stools. Bacterial causes are Salmonella, Shigella, Campylobacter, Yersinia, E. coli, different types. The history should show if other people are sick at home, travel, and child care attendance. Exam to assess for degree of dehydration and vital signs. Labs, stools for white cells, a stool culture and ovum parasite testing must be done, and the result will guide therapy since it is not advised to give antibiotics to some causes. Treatment: oral rehydration with solutions like Pediatric. Then resume an age-appropriate diet. If breastfeeding, then do not stop. May temporarily stop lactose-containing milk if it makes it worse. Indications for antibiotic therapy. In Salmonella, if less than 6 months of age or immunocompromised, antibiotics may cause carrier state. Ceftriaxone, azithromycin. In Shigella, if severe or immunocompromised, ceftriaxone, azithromycin shorten the course and decrease spread of infection. In Campylobacter, if severe, azithromycin. Yersinia, ceftriaxone, Bactrim aminoglycosides. In E. coli, certain types like enterohemorrhagic type, antibiotics are contraindicated because they may make it worse. Intussusception is a condition where part of the terminal ileum telescopes into the right colon through the ileocecal valve. The peak age of onset is 4 to 24 months. It causes obstruction initially and then ischemia later, since blood vessels get pulled along and are compressed. It presents with intermittent abdominal pain, while looking in between or sometimes lethargic, and blood in the stools, the classic so-called red currant jelly looking stool. Exam may show a sausage-shaped mass in the right hypochondrium. Sonogram will show telescoped bowel. Air contrast enema can be diagnostic and also therapeutic by reducing it, thereby avoiding surgery. Surgery will be needed if this fails. Intestinal duplications may occur anywhere from the mouth to the anus, but the commonest site is in the small intestines. It's a tube-like structure lined with mucosa from the small intestine, stomach, or colon, connected to the GI tract, and located on the mesenteric side of bowel. Those with ectopic gastric mucosa may have peptic ulceration and bleeding. It may present with pain, obstruction, intussusception, bleeding, or perforation. Vascular malformations. This is a congenital lesion. It can occur anywhere along the GI tract. It may be arterial, venous, or hemangioma, which is a benign blood vessel tumor. It may present with painless bleeding, and the color depends on the level of the bleed. It may be associated with cutaneous hemangioma or cardiac defects. Necrotizing Enterocolitis. This is a condition seen mostly in premature infants, but sometimes in term infants who are sick. Most are still in the NICU from delivery. The cause is not known. It presents with poor feeding, lethargy, temperature instability, abdominal distension, bilious vomiting, and blood in the stools. It may be mild, just poor feeding and blood in the stool, or severe, with septic shock and bowel perforation. There is inflammation of the distal ileum and colon that may progress to ischemic necrosis and perforation. The classic X-ray finding is bubbles of gas in the submucosal layer of the bowel wall, pneumatosis intestinalis. The treatment is to stop feeding by mouth, IV fluids and feeding, IV antibiotics, and surgery if complications like perforation are present. Malrotation of the gut with volvulus. This is a congenital condition. It occurs in the first trimester of fetal development. The GI tract starts as a straight tube. Then at 5 weeks of development, the middle part leaves the abdominal cavity into the umbilicus. It then re-enters the abdomen, rotating around its main blood supply, the superior mesenteric artery. This rotation places the cecum initially in the left upper abdomen, and then it moves to the right lower abdomen. This stretches the base of the small intestine mesentery, thereby preventing it from twisting and causing obstruction. If the rotation fails, the cecum remains on the left upper side, causing a narrow base to the mesentery, and also fibrous bands called Latz bands now pass over the duodenum, which may cause possible obstruction. The narrow base of mesentery may cause it to rotate, which may obstruct the superior mesenteric artery. This leads to bowel ischemia, necrosis, and blood in stools. This is called volvulus. This often presents by about 4 weeks, with bilious vomiting if only obstruction of Latz bands, or if a volvulus, then with bilious vomiting, abdominal distension, and blood in the stools. In the labs, an upper GI series contrast study is the best to make the diagnosis. Treatment is by surgery.